following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
Welcome to Doctors on Call. Tonight's topic, breast cancer. Two experts are here to answer your questions. Here's tonight's host, Dr. John Phillips.
National Breast Cancer Awareness Month begins in a few days. This is when we turn our attention to the critical issue of early detection. It's common medical knowledge that the sooner breast cancer is found and treated, the better the chances of survival. So what are the latest technologies for early breast cancer detection? What about the latest treatment options? What are some of the risk factors of breast cancer, and how can lifestyle help prevent it? We'll get answers to those questions and more from our two guests, Dr. Hannah Hazard, a surgeon specializing in breast care at WVU's Mary Babb Randolph Cancer Center, and Dr. Lisa Jacob, a plastic and reconstructive surgeon at WVU's Mary Babb Randolph Cancer Center. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. Hannah, we'll start with you. How common is breast cancer?
So breast cancer is actually very common. The statistics now represent that about 1 in 8 women will get breast cancer. So that means anybody that we basically know is in some way going to be touched by breast cancer. And so it is about 1 in 8 women.
And Lisa, you're a plastic surgeon, so you're part of a team caring for the folks?
Yes, Hannah and I work together as a team. She's the breast surgeon. She'll treat the actual breast cancer, and then I'm responsible for either making the defect of the breast look better or actually reconstructing a breast.
Okay. Now men can be affected as well.
Sure, men can be affected. It's much rarer. So the men are actually about 1% of all breast cancers that are diagnosed are actually in males. So it's a rare entity and is definitely treated surgically, and then oftentimes will also be treated with some other means of systemic care.
Okay. Well, we'll get into treatment for sure. Why don't we start with symptoms, what folks should worry about or be concerned about as far as symptoms go?
So most women have been taught to do self-breast examinations by their primary care providers. And so what women are looking for when they're doing self-breast examinations are any changes. And a lot of women will complain that they can't really tell because their breasts seem to have lumps or masses everywhere. But truly, the data seems to support now that women who do self-breast exams sort of by de facto when they're doing showers, their showers are the ones that are going to actually technically find something that's concerning. So we talk about masses that don't vary in size by cycles. Those tend to be, when that does happen, tend to be more cystic and benign or non-cancers. Occasionally, very rarely, women will develop spontaneous nipple discharge that's bloody, and that's a very rare symptom of breast cancer. But most often it's something that women feel on exam or when they do their mammograms, when they do their screening mammograms, it'll be detected that way.
Well, we could talk about screening then. How often does someone need a mammogram?
So the current recommendations are that women should get yearly mammograms starting at the age of 40. And these are just average risk women, so women who don't have very strong family histories. And so yearly, starting at the age of 40. And there was a little bit of controversy about a year ago regarding screening mammography recommendations, but as it stands right now, the current recommendations for a variety of organizations is yearly mammograms starting at the age of 40.
Okay, excellent. We're talking about breast cancer tonight with Dr. Hannah Hazard and Dr. Lisa Jacob. If you have a question about breast cancer for our experts, please give us a call. The phone number is on the prompter now or the screen now. So as far as treatment goes, if you've been diagnosed with breast cancer or you suspect it, what are some of the treatment options?
Well, you want to see a breast surgeon or a general surgeon who will be able to treat and diagnose the type of tumor that you have. And then what's always important is that if you're interested in breast reconstruction, you'll want to consult a plastic surgeon as well so that you can discuss your reconstructive options.
And you were saying before the show, it's some folks or some women, the plastic surgeon isn't involved early, and it'd be important for them to be involved early.
That's true. All women who are diagnosed with breast cancer are covered by the Women's Health and Cancer Rights Act of 1996. It was passed by Congress, and that actually implores your health insurance company to cover all stages of your breast cancer treatment from the time you're diagnosed through your mastectomy and then any type of reconstruction you might have. And even though we're talking about breast cancer on one breast, you may need a symmetrizing procedure on the other breast, and that would also be covered as well. And then when we're talking about breast reconstruction, we can talk about immediate reconstruction versus delayed reconstruction, and we can get into that a little later.
Okay. Well, before surgery, though, does everyone get chemo or radiation?
So that's a great question. When I talk to patients, I tend to try to break things down and make it as simple as possible. The problem and the benefit of breast cancer is there's so much research out there and there's so many options for women. It can be a little bit overwhelming. So when we talk about treating breast cancer, we have to talk about treating not only the breast and getting the breast cancer out itself, but oftentimes your doctor or your medical oncologist will talk to a patient about systemic treatment or treatment for the whole body. And that usually comes in the form of three varieties of options. One is chemotherapy, which is the one that women always sort of dread to hear the word. One is also anti-estrogen therapy, which is actually a pill that women will take for 5 years. And then there's a newer drug called Herceptin. It's a specific targeted agent. And so once that determination has been made by the medical oncologist, then that's when we proceed on with any surgery. For some women who have large tumors, when they present, maybe giving them chemotherapy first helps shrink that tumor down, so that way it becomes an easier surgery for me or the general surgeon or breast surgeon, and then gets that portion of their therapy out of the way.
Will it depend if the cancer has metastasized or traveled to other organs, whether or not they get chemo?
Exactly. So when we talk about breast cancer traveling to other locations, most often we talk about it traveling to the local lymph nodes, and those usually mean the lymph nodes in your axilla or underneath your arm. For some women, that may mean distant mets or metastases to lung, to bone, and to liver. When we're talking more about local metastases or local travel to the lymph nodes underneath the arm, that may impact the type of surgery that we may perform or your plastic surgeon and general surgeon will perform, but also may impact the type of systemic treatment like chemotherapy that may happen. Mm-hmm.
Okay, well, we have our first caller. It's Karen from Mercer County. Karen, welcome to Doctors on Call. Go ahead with your question.
All right, thank you very much. Yes, ma'am, I have a question. I was diagnosed with breast cancer on the left side of my breast in February of 2007, and after my surgery and everything, I wanted to know how often should I have a mammogram or any type of X-ray with the radiation on the left side of my breast that I had the cancer in?
Karen, may I ask you a couple of questions?
Sure.
What kind of surgery did you have? Did they just take out the cancer but leave the rest of your breast, like a lumpectomy?
Yes, I had a lumpectomy, but my breast is a lot smaller than my other side, okay? And now they found a lump the other day, and they're wanting to do an ultrasound on it. But every 6 months they had me going for, after I had my surgery in 2007, they had me going every 6 months to have a mammogram on that side, and then just have, like, on the right side, just have my regular yearly mammogram. And that's how I was diagnosed with breast cancer, because I didn't even know I had it. I had no pain. I could feel no lumps or anything in 2007. Because I was told too much radiation on that side can cause cancer. I wanted to know if that was true.
So actually, you bring up a couple of good points. Most women are diagnosed just like you are diagnosed. Most women don't actually have any symptoms. It's based on their screening mammogram, which is exactly what you had done. And that's why we advocate for screening mammograms, because we want to find them before we can actually feel them. When you have a lumpectomy, generally women get radiation therapy after to reduce the chances of it coming back in the same breast. Every practice is a little bit different, but mammograms every 6 months on that side, I don't think will have any impact on increased risk of getting cancer again in that side or even in the other side. The amount of radiation you get with a mammogram is incredibly small. So I think that the practice that has been established by your doctors is perfectly reasonable.
And then Lisa, maybe you could speak to Karen about, she's saying she's asymmetric now.
So the cause of that is a post-radiation therapy atrophy of the breast. The radiation therapy damages the skin and the breast tissue that's left. It also helps to kill, any kind of lingering cancer cells, and that's why it's beneficial in terms of for preventing local recurrences. But it's very common in patients who have had a lumpectomy and radiation to have a breast asymmetry. So the breast tends to contract and become smaller. And so there are things that can be done from that. We can symmetrize the other breast. We can reduce the other breast to match.
You've used that word twice, symmetrize. Can you explain to us what that is?
So obviously every woman wants their breast to be symmetric. Symmetrize is to make the breast symmetric and look the same. So we want to give the appearance of the breast, have them to be the same size and shape. And once a patient's had radiation, their breast appearance can change. So we can do things, like I said, to reduce the other breast to make it more symmetric with the other side, or actually do surgery on the radiated breast to make the appearance better. Sometimes there can be some contour deformities, or the nipple can be pulled in a certain direction after the radiation.
Very good. Karen, best of luck to you. Our next caller is Alicia from Marion County. Alicia, welcome to Doctors on Call.
Hello.
Yeah. Hi. You have a question for our experts?
Yes. I was wanting to know, does Avista prevent, or is there statistics that support that it prevents breast cancer?
So that's a great question. Avista is one of the anti-estrogen medications that has been produced. It was initially actually produced for bone density loss, so for women who are undergoing or needed medicine to improve their bone density. And one of the things that they noticed giving this to women was that there was a reduction in the amount of breast cancer in this patient population. So the simple answer is yes, it does reduce the risk. And it's a drug that you take for 5 years, once a day.
When would you prescribe that?
So there are a couple of ways. We usually use it for risk reduction, so either or in treatment for breast cancer, most often for risk reduction. And so when I talk about risk reduction, I mean women, when we talk about standard screening recommendations, we talk about women who are just at average risk. But there are a group of women, they're small, but there's a group of women out there who are considered to be above average in their risk or high risk. And sometimes those women have the designation or are called high risk because of a strong family history of breast cancer or a strong family history of ovarian cancer, or because of some of their own innate pathology or biology. So sometimes women will get breast biopsies and they'll find some atypical cells. Those cells aren't cancer, but those cells may indicate that that woman may have an increased risk of breast cancer. And so in situations where we've defined women as being at an elevated risk for breast cancer, taking a medicine like Avista will be.
Even before they have cancer?
Even before they have.
Amazing. Okay, our next caller is Amy from Wood County. Amy, welcome to Doctors on Call.
Hi.
Hi. Go ahead with your question.
I found a lump in my breast back in June or July, and it's about the size of a small grape, and it doesn't hurt. It looks a little purplish through the skin, and I just wondered, is it really important that I get it checked? I mean, I know that sounds stupid, but are there signs that can say that it isn't anything, that it's just a fatty tumor, and I don't need to worry about it, or?
Definitely not a stupid question.
Yeah.
And we have an answer for you.
Like we say in medicine, there are no stupid questions. So any change to your breast, whether it's on self-examination, by palpation, or by looking at yourself in the mirror, warrants some sort of evaluation. Most often it ends up being a non-cancerous cause, which is a great thing. But one of the things that we try to advocate is if there's some change, then to have it evaluated. And sometimes that can be just something as simple as going to your primary care doctor and having a breast exam. Sometimes that will generate a mammogram and or an ultrasound, a little bit depending on the age of the woman as well as what they're finding on exam. And so sometimes you end up going down that pathway, and it tends to be a little overwhelming for patients. However, in the end, most of the time that generates something that is a benign, non-cancerous thing, and then there's peace of mind associated with it.
Okay. Our next caller is Judy from Point Pleasant. Judy, go ahead with your question.
Yes, I'm calling about my sister-in-law, and anyway, she's got breast cancer, and she's took several chemo treatments. Okay, they thought, that it would be small enough where they could do surgery, but they have recommended more chemo. So I was wondering, is there any way this can metastasize whenever, while she's taking chemo?
So it's a good question. Sometimes women present with tumors that are just too large for a surgeon to be able to get around them. And not by get around them, I mean be able to take them out and be able to take out all of the tumor. So we term that as negative margins. And so if women are evaluated by their surgeon and they feel like they can't take out that tumor at that time, then the best chance of us being able to take out that tumor is by giving chemotherapy first. Occasionally, we will have to stop giving chemotherapy and just remove the tumor, but oftentimes it may mean that we actually take more skin than will allow us to be able to bring everything back together. And so when that happens, going and seeing a plastic surgeon about not breast reconstruction, but breast or chest wall reconstruction is very important. And I think probably Lisa could
sometimes
talk
you'll
about.
be in the operating room together. How does that work?
Yeah, my job is to, like Hannah was saying, in a patient who has an extremely large tumor that may be involving the skin, we would do a chest wall reconstruction, taking muscle and skin from the back to reconstruct the defect on the chest wall. And then other times when we work together, I'm doing a breast reconstruction. So usually we like to do an immediate reconstruction that's done at the time of the mastectomy. So Dr. Hazard's job would be to take the breast off, but we do usually what's called a skin-sparing mastectomy or a nipple-sparing mastectomy, so that leaves the skin envelope of the breast, and then my job is to fill it, typically with either an implant or the patient's own tissue to recreate a new breast for them.
Okay, and you said that the sooner you do it, the better results you get?
Right, so if we do it at the time they're getting the mastectomy, it leaves sort of the skin envelope of the breast, and so that makes it much easier to recreate a reconstructed breast that looks more like their native breast.
Is that because of scarring with time, or?
Because we have sort of the skin envelope to fill with something, either the patient's own tissue, typically belly tissue or back tissue, or if they don't have enough tissue to use, we use an implant. And then we can put that into the breast, usually underneath the chest wall muscle, and to recreate a new breast.
Okay, very good. Our next caller is Eva from Raleigh County. Eva, welcome to Doctors on Call.
Thank you. How are you this evening?
Very well. Go ahead with your question.
Yes, I was diagnosed in 2004 with intraductal carcinoma, and 6 months later I had been diagnosed with 2 other types of cancer in the other breast, and one of them was intraductal carcinoma, and the other one was a tubular carcinoma, and I was on a Remedex, and it caused so much joint pain, and I was wondering, is that a common side effect? I had to have a double mastectomy. When they found the place come up, I didn't even wait to see if it was malignant or not. I chose to have a double mastectomy, but I was on the Remedex, and the joint pain and stuff that I had from that was unbearable, so I went off of it. And I was just wondering, is there other medicines that maybe could have been prescribed?
So it's a great question. And almost every woman who takes a Remedex or something medicine like that will have some amount of joint pain.
What is it?
A Remedex is a anti-estrogen agent. It's again a pill that you take. There are a variety of them. There are 2 different big classes of these medicines. The one that a Remedex is part of is called an aromatase inhibitor. And there are actually 3 that we use commonly in the United States. And it's, again, a pill you take for 5 years. It reduces the chances of a recurrence of breast cancer. And most of those pills have some version of joint pain. And what I've noticed our medical oncologists do is if one of those 3 tends to give more joint pain, then they'll give the patient a little bit of a holiday from the medicine, and then they'll start another medicine, a different version of that medicine, although the same class, just to see if maybe they tolerate that better.
How common is it to have breast cancer in both breasts at the same time?
It's pretty uncommon. And so usually it is more associated with an initial diagnosis of an invasive lobular cancer as opposed to an invasive ductal cancer, but it's pretty rare. There was a study published in 2006, and a group of radiologists basically took every woman who was diagnosed with a breast cancer, and every one of them, no matter what the type of breast cancer, they were given bilateral breast MRIs. And breast MRIs tends to be our most sensitive test. And in that whole cohort of women, and it was over 1,000 women, only 3% of those women actually had a breast cancer in the other breast that wasn't detected by standard screening tactics like breast exam, mammograms, ultrasounds.
Okay, very good. Eva, best of luck to you. Our next caller is Carrie from Wirt County. Carrie, welcome to Doctors on Call.
Thank you.
You're welcome. Go ahead with your question for our experts.
Yes, I was just wondering, a lady like with dense breast, I mean, every time she has a mammogram, you know, they say she has dense breast. I've heard that maybe they're more likely to get breast cancer. Is that right?
Yes, that actually is true. There have been a couple of studies out that show that women whose breast makeup is a little bit more dense in comparison, particularly the older women get. So there's a slight increased risk of getting breast cancer.
Why is it more dense?
So there are a lot of factors. Usually dense breasts are younger women. So because that tissue is designed to produce milk and to feed children when you're having children. And as you get older and you go through menopause, the body recognizes that's no longer the function. And therefore the breast becomes what we call fatty replaced. And so it sort of thins out and it doesn't feel as firm. Some women will have breasts that are dense because they're taking hormone replacement therapy, and so will actually keep the breast at a state which much younger than it actually is, and so some of that can be attributed to it. Other women just tend to have denser breast tissue.
Here's a stupid man question.
No such thing.
Breastfeeding doesn't affect your risk for breast cancer?
Not at all. Some people actually believe it helps with your risk.
Okay. And as far as age goes, it's not necessarily your age, it's your hormones.
To some degree. So it's age by proxy. So what I think you're trying to sort of get at is the increased risk of breast cancer comes from what we call prolonged estrogen exposure. So women who start their periods at a younger age, 8, 9, 10, and women who don't go through menopause until a later age and have not had very many children in that time span are a little bit of an increased risk for getting breast cancer because they have sort of uninterrupted estrogen exposure.
Okay. Very good. Our next caller is Dee from Summers County. Dee, welcome to Doctors on Call.
Hi, good evening. I have a question for you all. I am 66 years old. I had 2 bouts of breast cancer. My first one was in 2000 on my right. I had mastectomy, chemo, and radiation. It came back on my left in 2006. I had again a mastectomy and chemo, and I was placed on Arimidex for 5 years. Tomorrow is my last day of my Arimidex. Thank you for that. And what shall I do to detect any recurrence of that?
Very good.
First of all, congratulations on tomorrow being your last day of your Arimidex therapy. That's a big milestone for you. So when we talk to women about mastectomy, whether or not they've been reconstructed or not, what is really important is basically your chest wall examination. So if you've had reconstruction, basically what is left is the skin envelope, like we had talked about, as well as just some of the subcutaneous fat. But there's not what a plastic surgeon like Lisa does is actually fill that up with something that doesn't have breast tissue in it. So the chest wall examination becomes very important. So feeling the prior scar, feeling the chest wall from your collarbone all the way out towards your arm, and then towards your breastbone, and you just basically monitor your chest wall. You bring up a very good point, if I may, is a lot of women feel at the end of that, like the day after tomorrow, it becomes a little bit unsettling for them because they have been going through so much to treat their cancer. They have been taking an active role in it. And then all of a sudden it sort of, all of that activity goes away and now you sort of have to trust. And so it can be a little bit disconcerting for women.
Sure. And that's why it needs to be a team approach, and not only surgeons and doctors, but other support groups should be involved as well.
Absolutely. I think one experience I've had in dealing with breast cancer patients is it just always astonishes me how much support they get from other women with breast cancer. So there's a lot of support groups for women with breast cancer, and it's important for them to reach out to those groups because they can feel isolated with a breast cancer diagnosis, and they want to feel, reaching out, they'll feel more part of a community. And I think this month brings up a lot of breast cancer awareness, but there are events and things that go on all year that raise breast cancer awareness, funding for breast cancer, research and breast cancer treatments. And I encourage all women to reach out to other women to talk about breast cancer.
Excellent. Very good. Well, we've been talking about breast cancer with Dr. Hannah Hazard and Dr. Lisa Jacob. Thank you both for being with us. If you would like more information, see your family doctor or visit our website at wvuhealthcare.com. For Doctors on Call, I'm Dr. John Phillips. Good night and good health.
Join us next week for another edition of Doctors on Call.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.